Good morning, everybody. Good morning, everybody. We'll go ahead and get started. Ms. Jackson is going to start her presentation right now.
Good morning, everyone. My name is Charnel Jackson. I am a licensed professional counselor. My background extends to working in juvenile corrections, child protection, and foster care at our state mental hospital in Jackson, Louisiana, with rape crisis, as well as I am a private practice practitioner. And so, in a lot of my background, I've worked closely with the legal profession. Currently, I am also a contract therapist with the Southern University Law Center to provide therapeutic services for the students who are enrolled. And so today I will be presenting to you guys on mental health and the legal profession, a balancing act. So just a few rules to start with. Please ask questions when you have them. I like to be interactive. I know this is virtual, but you can still put your questions in the chat. Please do not diagnose yourself or anyone you know using any of the information presented. If I can't read a law book or two and decide to go to court and be an attorney, you cannot look at my presentation today and decide to be a therapist. So we do need diagnosis to be by people who are trained. If you are experiencing any life-threatening situations or symptoms, please go to your nearest emergency room or call 911 and seek help from a licensed mental professional if you have any questions or concerns about your mental health. So we are going to start off with statistics when it comes to mental health and the legal profession. So the Dave Nee Foundation found that depression among law students is 8 to 9% prior to matriculation, 27% after one semester, 34% after 2 semesters, and 40% after 3 years. So this is important. This stress, the depression, and the things that are going on with the legal profession is starting in law school. Stress among law students is 96% compared to 70% in medical school and 43% in graduate students. I think that stress level has a lot to do with the way law school is structured and what the expectations are for students. Entering law school, law students have a psychological profile similar to that of the general public. After law school, we're looking at a 20 to 40% increase in them having psychological dysfunction. And so whatever it is that is happening during law school is causing some type of psychological issue for those students, and they are taking that with them into the profession. Psychological distress, dissatisfaction, and substance abuse that begin in law school do continue to follow many of our graduates into practice. Lawyers are the most frequently depressed occupational group in the United States. And so when we think about that, that means that there is a colleague of yours that is more than likely depressed. It's someone you know that works in the legal profession that is experiencing symptoms of depression. Lawyers are 3.6 times more likely to suffer from depression than non-lawyers. So depression and anxiety is cited by 20%, 26% of all lawyers who seek counseling. These are just the people who are actually coming to therapy. This does not count people who are self-medicating, who are ignoring their symptoms, or who aren't acknowledging that they have an issue. Lawyers rank 5th in incidents of suicide by occupation. Veterinarians are pretty high on the list. I think they are number 1, but being 5th in when we look at all occupations as a whole, that is a significant issue that we look at. So I've included some clinical definitions of how we define what depression is and what our other mental health diagnoses are. We don't just make up labels or define that people are depressed and pull it out of a hat. We have to meet a certain criteria. And so that criteria is found in the DSM-5, and DSM stands for the Diagnostic and Statistical Manual. It is our Bible. It is how we determine whether or not people meet criteria to be diagnosed with a disorder. All of the disorders that you could possibly be diagnosed with are found in the DSM. So for depression, we are talking about a person having 5 or more of the following symptoms having been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either 1, depressed mood, or 2, loss of interest or pleasure. So we're not talking about just sadness, I feel blue. We're talking about significant mood changes that are going to happen over a 2-week period. So here are the criteria. These people are depressed most of the day, nearly every day, as indicated by subjective report. They're saying that they feel sad, empty, or hopeless. Or this could be observations made by other people, that the person appears tearful, that they look withdrawn, they look like they're just not themselves. Then we have markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, as indicated by subjective account or observation. So these people are not doing the things that they used to find interesting or find pleasurable. If they were a person that liked to travel, no longer will they travel. If they enjoyed reading, they may not be reading anymore. And so the things that they used to do with other people or even for themselves, they're no longer doing. Significant weight loss when not dieting or weight gain. And so when it comes to weight, we find that people are on one side of the continuum or the other. They are either gaining weight because they are overeating during their depression, or they are losing weight because they don't eat during their depression. And so usually we're looking at a 5% change in body weight within a month. We then have insomnia or hypersomnia nearly every day. And so that is also on a continuum. You have people who are depressed who don't sleep at all, and you have people who are depressed who sleep a lot. And so those are also on the same continuum. We also have psychomotor agitation or retardation nearly every day. And this is usually more observable by others, not just by subjective feelings of restlessness or being slowed down. And so for these people, we might look at them and say, you know, they just look like they're lethargic. They don't seem like they have any energy. Seems like something is off or going on with them. Then we have fatigue or loss of energy nearly every day. And we can't figure out why. So we may be fatigued as soon as we wake up in the morning, or may not have energy to complete our tasks. We have feelings of worthlessness or excessive or inappropriate guilt. And sometimes that might be delusional, but this occurs nearly every day. And it's not merely self-reproach or guilt about being sick. And so when we say that some of the inappropriate guilt might be delusional, a delusion is a thought that is not based in reality. And so sometimes that guilt is because someone has basically thoughts that they owe people something, that they're responsible for certain things, that they've done things that are wrong, but they're not based in reality. And that can be a part of depression also, although typically we see delusions in our thought disorders. There's a diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account or as observed by others. So this is a big one, especially when we're thinking about law school or just the general practice of law. If you're not able to concentrate and make decisions, that definitely has a significant impact on how you actually participate in your career or in school. And then our final one is recurrent thoughts of death, not just fear of dying. So we have recurrent suicidal ideation without a specific plan, or a suicide attempt, or a specific plan for committing suicide. And so when we talk about recurrent suicidal ideation without a plan, this could be passive. This could be thoughts like, I just wish I wasn't here. Things would be better off if I wasn't here. I wish I was never born. So those are some of the things that we see that we consider to be passive suicidal ideations. Then we have actual suicide attempts. So that is when people actually go through with a plan. And then sometimes people plan how they want to commit suicide from start to finish, but they don't actually participate in the process. And so depression can be quite debilitating. Oftentimes when we think about depression, people say, oh, you should just snap out of that. You just sad, perk up. And it's not that easy. There are people who are depressed who can't get out of bed. There are people who are depressed who cannot actually participate in their daily life. And so it's important to remember that this is actually a disorder. This is not about being sad for a couple of days. So our next category that I'll talk about in terms of diagnoses is anxiety. And so anxiety, according to the American Bar Association and the Hazel and Betty Ford Foundation, is the most common mental health condition reported and accounts for 61% of the sample for the study that they did. Social anxiety was reported at 16.1%, and panic disorder was reported at 8.0%. In general, when we think of anxiety, anxiety is typically caused by a lack of control and our reaction to the fact that we can't be in control. And so when we start talking about how do we diagnose anxiety, our first disorder is generalized anxiety disorder. And so this is the presence of excessive anxiety and worry about a variety of the topics, events, or actions. Worry occurs more often than not for at least 6 months, and it's clearly excessive. And so there are things that we all worry about or that we're all concerned about that might be considered normal. But when that worry starts to become excessive, it's lasting for this long period of time. It can be a variety of different things, but this person is consistently worried about things. The worry experienced is very challenging to control. The worry in both adults and children may easily shift from one topic to another. So we're looking at people saying, oh, well, I'm not going to worry about that anymore. But they find that they're continuing to worry. Also, if something that they are worrying about tends to get resolved, they then still transfer that worry to another topic or another item. The anxiety and worry are accompanied by at least 3 of the following physical or cognitive symptoms. And in children, we only need 1. So we're looking at edginess or restlessness, tiring easily, more fatigued than usual. You will see that some of these symptoms overlap some of the symptoms for depression. And that's because anxiety and depression can feed off of each other. So it's not uncommon for us to see one and then also see the other. Impaired concentration or feeling as though the mind goes blank. Irritability, which may or may not be observable to others. Increased muscle aches or soreness. And so that comes from the fact that people who are worried all the time and who are stressed all the time, they tense their muscles. And so if your muscles are tensed all day, every day, they start to hurt. And so we have those muscle aches. And then difficulty sleeping due to trouble falling asleep or staying asleep, restlessness at night, or unsatisfying sleep. Often my clients who have anxiety tell me that they can't turn their brains off. When they settle down at the end of the night, all of the stuff that they're worried about, that's when it starts to present itself when they're trying to relax and go to sleep. So then they have a hard time actually falling asleep, or sometimes those thoughts wake them up. And so anxiety can be very difficult for a person to deal with. Anxiety disorders are on a continuum. So our other disorder that we'll talk about that's on that continuum is panic disorder. So when we talk about panic disorder, this is when people are actually having panic attacks or anxiety attacks. Sometimes people end up at the hospital thinking that they're having a heart attack because they're having a panic attack. So the diagnostic criteria for a panic disorder as defined by the DSM-5 is based primarily on the occurrence of panic attacks, which are recurrent and often unexpected. In addition, at least one panic attack is followed by 1 month or more of the person fearing that they will have more attacks and causing them to change their behavior, which often includes avoiding situations that might induce an attack. It's important to note that a panic disorder diagnosis must rule out other potential causes for the panic attack. And so when we're talking about panic and anxiety, oftentimes what people do is they avoid the thing that causes it. That kind of makes logical sense. If something's bothering me and it causes me to panic or causes me to worry, I avoid it. But with anxiety disorders, what happens is that reinforces the fact that this thing causes that. And so once we start to avoid it, it gives that particular thing or that particular person even more power. So when we talk about panic attacks, the attacks are not due to the direct physiological effects of a substance. So it's not induced because we're high, because we're drunk, or because we're taking actually sometimes prescribed medication. And it's not due to a general medical condition, because we do have some medical conditions where we might consider anxiety to be attached to those. The attacks are not better accounted for by another mental disorder. So these disorders include social phobia or another specific phobia, obsessive compulsive disorder, post-traumatic stress disorder, or separation anxiety disorder. And so those are some of the other diagnoses that are actually on that continuum when we start to talk about anxiety. When we talk about social anxiety, that is usually falling underneath that umbrella of general anxiety disorder, but it's specifically about speaking in public or going places. People with social anxiety will tell you, like, if they go to the mall, they feel like everybody's looking at them or judging them. And so it impacts their ability to interact with the public. Our next section is on alcohol addiction. I was not able to find a whole lot of statistics on other substances, but the American Addiction Center worked with a study with the ABA Commission on Lawyer Assistance Program and the Hazelden Betty Ford Foundation. And they indicate that 21% of lawyers and in the legal profession are considered to be problem drinkers. So that 21%, these aren't people who actually have a diagnosis yet. These are people where we can look at them and say, oh, they drink a little bit too frequently, or, you know, they get drunk more often than we would like. So 36% of attorneys struggle with actual alcohol abuse. So almost half of the lawyers in the study indicate that the drinking issues began during the first 15 years of their career, which included their time in law school. So now I'm doing therapy with law students. And guess what they're doing to cope with law school, y'all? They're drinking. That's been happening for a long time. Okay. Okay. So it becomes maybe a part of the profession that's socially acceptable. But the law students are drinking. That's how they're coping with their stress. So then when we start looking at the substance use disorders, the way they are characterized is they are labeled based upon the actual substance. And so there are 10 classes of drugs that they look at. So we're looking at alcohol, caffeine, cannabis. The law students are smoking weed, y'all. Hallucinogens, inhalants, opioids, sedatives, hypnotics or anxiolytics. I'm sorry, I always mess that word up. Anxiolytics, tobacco, or other unknown substances. The other thing that we are seeing a lot is Adderall or other stimulant drugs. So we're seeing quite a few students are using those drugs to study. And so they begin using those substances in law school, but that addiction or that behavior continues. So the way we diagnose someone with an actual substance use disorder is they are taking a substance in larger amounts or for longer than they meant to. So, I'm just going to have 1 or 2 drinks today, or, and they end up having 5 or 6, or I'm just going to go hang out for a couple of hours and they end up staying out all night. Wanting to cut down on or stop using the substance, but not managing to. So there's a desire to stop using, but they're not able to actually put that together. Spending a lot of time getting, using, or recovering from the use of substances. When a person truly has a substance use disorder, it's a full-time job. So either they are figuring out how to get the drug, what do they need to do to get it, they are using it, or they are recovering from it. And so it is a cycle. And so much of their time is spent focusing on the substance. Cravings and urges to use the substance is also a piece. So when we start talking about cravings and urges, we have 2 different parts that go into that. We have the psychological need, where we feel like we need this substance in order to make it or to cope. And then we have the physiological need, where our body is actually craving this particular substance. So our next one is not managing to do what you should do at work, home, or school because of substance use. So we're not able to fulfill our obligations. Continuing to use even when it causes problems in relationships. So family members, friends, spouses, romantic relationships, all of these are impacted because of the substance use. Giving up important social, occupational, or recreational activities because of substance use. So are people not going to these things and not participating because they choose to go and get high or get drunk instead? Or are they so drunk and high that they actually are missing out on things? They don't remember where they're supposed to be and when they're supposed to be there. Using substances again and again, even when it puts you in danger. So I see we have a hand raised, Ms. Jefferson. You can ask your question or you can type it in the chat. Okay, so that was an accidental hand raise. Sorry about that. All right, so the other pieces that we need when we start talking about substance use. Continuing to use even when you know you have a physical or psychological problem that could have been caused or made worse by the substance. So if we have cirrhosis of the liver, but we still go out every week with the boys to have a drink, or if we have lung cancer, but we still continue to smoke every day. Those would be examples of there being a substance use issue. Also, a lot of times people use marijuana and alcohol to try to deal with their depression and or their anxiety. When we talk about anxiety, depression specifically, these people are using things that are considered to be downers or depressants. So you're using a depressant to deal with your depression. When we say it out loud, does that really make sense for us to do that? So needing more of the substance to get the effect you want, that's developing a tolerance. So maybe once upon a time, you could do 2 shots and you'd get your buzz or you'd feel good. Now you need 4, maybe you need 5 to get that same effect. And then development of withdrawal symptoms. And so when we talk about that, oftentimes it can be relieved by taking more of the substance. So in particular, withdrawal is very prevalent when we talk about alcoholism. People who are alcoholics can go through a process called DTs, and that is where they are withdrawing from alcohol. It's actually one of the more dangerous substances to withdraw from. We usually ask people to do a medical detox if they're doing an actual, they're trying to get sober. DT starts off with shakes. It can include hallucinations, and it definitely affects how our body works physiologically. Another example would be opioids. When people use opioids, they often get to a point in which they are no longer using for pleasure. They're just using because they are trying not to be sick. It's called dope sick. And so when people are dope sick in terms of opioids, we are looking at feelings of probably the worst case of the flu that you've ever had as your body tries to detox from that substance. With substance use disorders, they are on a continuum. And so we look at the severity. And so it's determined by the number of criteria met. So a mild substance use disorder would be 2 or 3 of these symptoms. A moderate substance use disorder would be 4 or 5, and severe would be 6 or more. So of course we want to catch people when it's mild. We don't want to have to wait until we're in a severe place. And so a part of that is education. A part of that is intervention, and helping people to realize that self-medicating or using these substances in order to numb feelings or cope with life is typically not going to put us in a good place. Our next one is personality disorders. Has anybody ever heard the term personality disorder before? Okay. You haven't been called that? Okay. All right. So we have a hand raised from Courtney Thornton. So you can actually either type your question or you can unmute yourself. I'll wait for that, kind of keep going and wait for that question to pop up. When we talk about personality disorders, 17.6% of attorneys were found to have antisocial personality disorder compared to 3.2% when we look at the general population. 11.7% of attorneys were found to have narcissistic personality disorder. And when we look at the general population, that's 6.2%. So both antisocial and narcissistic personality disorders have a significant correlation with addiction and substance use disorders. And so because there is a correlation, there is a significant relationship between people having these disorders and using substances. Thank you, Courtney. Okay, so when we talk about, in general, what is a personality disorder? It is a deeply ingrained pattern of behavior of a specified kind that deviates markedly from the norms of generally accepted behavior, typically apparent by the time of adolescence, and causing long-term difficulties in personal relationships or in functioning in society. So these disorders are happening during our formative years. One big piece to remember about personality disorders is we don't treat them with medication because the medications do not work for them. So everything else we've talked about up until now, we can use medications as a part of our treatment plan. With personality disorders, that is not possible. We do not use medication. So I will give you a description of the 2 disorders that we're seeing in the legal field. Our first one is antisocial personality disorder. So when you guys hear the word antisocial personality disorder, what do you typically think of? And you guys can type your answers in the chat if you're virtual. Crazy? Okay. When we hear antisocial, what else do we think about? Introvert. Okay. Somebody that doesn't want to be bothered. Okay. So typically, sounds like somebody who would be isolating behavior, someone who doesn't speak to anyone. In layman's terms, y'all are absolutely correct. But clinically, it is totally different. When we think about it clinically, we're talking about people who are anti-social norms. They are not participating in social activities and social norms the way the rest of us do. They don't acknowledge the rules. So antisocial personality disorder is also sometimes called sociopathy. So when we talk about sociopaths, that's where we're coming from. And it's a mental disorder in which a person consistently shows no regard for right or wrong and ignores the rights and feelings of others. People with antisocial personality disorder tend to antagonize, manipulate, and treat others harshly or with callous indifference. They show no guilt or remorse for their behavior. When we look at long-term incarcerated people, a lot of them are antisocial. And what'll tell you that they're antisocial is their crimes are all over the place. So they might have a burglary charge over here. They have a distribution of drugs charge over there. They got a rape charge over here. It's just because it's whatever they feel like doing in that moment. So it's not staying in one category. So when we diagnose it, we're looking for disregard and violation of others' rights since age 15. So again, adolescence, this is starting pretty early. And so it has to be indicated by one of the 7 sub-features. They are failure to obey laws and norms by engaging in behavior which results in criminal arrest or would warrant criminal arrest. So even if you didn't get caught, but you're still doing the behavior, that counts. Lying, deception, and manipulation for profit or self-amusement. Impulsive behavior. Irritability and aggression manifested as frequently assaults others or engages in fighting. Blatantly disregards safety of self and others. A pattern of irresponsibility and lack of remorse for actions. This person needs to be at least 18 before we can diagnose them with antisocial personality disorder. If they are under 18, we are looking at diagnosing them with something called conduct disorder. You have to have been diagnosed with conduct disorder, or we can diagnose you by history before the age of 15, before we can diagnose you with antisocial personality disorder. So it's one of the few disorders that we have where we have basically a prerequisite. You have to meet certain criteria by a certain age. The final part is that the antisocial behavior does not occur in the context of schizophrenia or bipolar disorder. So we want to make sure that we separate that. The other disorder I told you guys about is narcissistic personality disorder. So narcissistic personality disorder is one of several types of personality disorders, and it is a mental health condition in which people have an inflated sense of their own importance, a deep need for excessive attention and admiration, troubled relationships, and a lack of empathy for others. But behind the mask of extreme confidence lies a fragile self-esteem that's vulnerable to the slightest criticism. Remember, I told y'all don't diagnose people. This sounds familiar. Maybe it's true, maybe it's not. So for a diagnosis of narcissistic personality disorder, we have to meet 5 of the following criteria. Grandiosity with expectations of superior treatment for others. Basically, when we're talking about a narcissist, they are the center of the universe. Everything is about them, 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 them. No comment. Fixated on fantasies of power, success, intelligence, attractiveness, etc. Actually, there were some psychologists that met and diagnosed Donald Trump with narcissistic personality disorder. Yes. Self-perception of being unique, superior, and associated with high-status people and institutions. needing continual admiration from others, a sense of entitlement to special treatment and obedience from others, exploitative of others to achieve personal gain, unwilling to empathize with the feelings, wishes, and needs of other people, intensely envious of others, and the belief that others are equally envious of them, and then pompous and arrogant demeanor. So when person, I should put his picture there. Yeah. So, you know, he wasn't anyone's client per se, but they did meet and examine his behavior and decided that he did meet the criteria. So, what makes lawyers more susceptible to mental health issues? So you guys they already have problems? Everybody else's problems coming to you. Okay, some of us are taking those things personally. You guys can type in the chat if you're virtual, some of the things that you think makes lawyers more susceptible to mental health issues. Dealing with crazy clients, okay. Pressure. Here go clients again, okay. Anybody else? One's texting you right now, okay. Deadlines. Clients' parents, okay. We might be dealing with some of the same people, y'all. Yeah. All right. So, lack of work-life balance, completely unreasonable expectation, the balance of clients and life. Okay, very good answers. So it doesn't stop, okay? So here are some of the factors. Time constraints and deadlines. Attorneys are pretty much always under pressure to get something completed by a particular time. If it's not for court, it's for a meeting, it's for something. High stakes involved, including loss of property, freedom, and even life. So oftentimes, whether we represent someone who we are prosecuting or that we're defending or that we are involved in family court with, or even if we're doing contracts and acquisitions, there is somebody has to lose. And sometimes that loss can be pretty heavy when we're talking about loss of life, loss of freedom. Those things can weigh heavily on a person. The high expectations of expertise and success. You're not really allowed to be a mediocre lawyer, are you? You're supposed to be good. And so that's a lot of pressure. The constant scrutiny and critical judgment of a lawyer's work from opposing counsel or the courts. So your work has to be top tier because there's somebody else waiting to poke a hole in it, waiting to find your loophole, waiting to find the thing that you didn't think about or that you forgot about. And so I think oftentimes that increases anxiety because we're trying to figure out all of the stuff and we're worried about, did I get it right? Did I catch everything? The inherently conflict-driven nature of the legal process. Our legal process is us against them. Yes. So that's the way it works. The threat of malpractice. So we live in a litigious society, which means y'all have jobs, but it also means that people can sue you too for not representing them properly. And that can also be pressure. A tendency to assume a client's burdens. People are coming to you with some pretty heavy stuff. And so perhaps attorneys can take a page out of the therapist handbook. We leave work at work. We don't take people's problems home with us. We're not getting paid for that time. And so learning how to participate in those boundaries is important. And so maybe that can be a part of training or workshops in order to learn how to leave that stuff at home. Okay, we have someone else saying that we think of concepts as opposed to accepting and dealing with our feelings. Okay, so that's another good one. And I don't have it listed, but attorneys do tend to think logically. And when we are in that logical mindset all the time, we're not thinking about the emotional piece. We don't deal with it. Okay. Let's see. Someone says that it's not possible to leave work at home when you're in private practice. I work in private practice. I know it's different than law, but at some time it has to be cut off. At some time we have to have boundaries. Sometimes we have to tell our clients that we're not available after a certain time, that we have to be able to do that work-life balance. Someone else is talking about the fact that work-life boundaries are more difficult in the pandemic work from home. Absolutely. When we're working from home, we don't have that separation anymore. We tend to work longer hours. Our clients are virtually in our space and in our homes. Our next one is the demise of professional cordiality and camaraderie. People just aren't nice anymore. They just aren't. The strain that a lawyer's advocacy skills can create when applied to personal relationships. So sometimes we are lawyering when we're not supposed to be. People are asking us for legal advice because they know that we are a lawyer. Then I've met some lawyers in private practice. They virtually in their minds put their family members, their spouses, their friends on the stand and interrogate them when they're trying to have conversations. What does that do for a relationship? You have to stop being the lawyer when you're talking about working in these relationships. The group norms or culture in a law firm have expectations such as high billable hours. So we're trying to make partner. If we're trying to work our way up the ladder, they want us to bring in money. They want you to be able to bring in new clients. They want you to be able to be at work first and leave last. And so some of those expectations are difficult, especially when our goal or our focus is professional development and being able to go up the career ladder. The depletion of energy that comes from high demands at work. We find that lots of attorneys are type A personalities. Type A's are very organized, very detail oriented. They make lists. Things have to be just so. They are the early bird gets the worm. And so they're very on top of things. Expectations of perfection set for self. So sometimes this pressure isn't just coming from outside, it's coming from an inward place. So it's important to remember that. Sometimes our expectations that we have of ourselves are too high. And then we have vicarious traumatization. When we watch the news and we see all of these horrific things that happen in our world, there's an attorney somewhere that has to look at the pictures. There's an attorney somewhere that has to read the police report. There's an attorney somewhere that has to talk to that victim from that crime or that survivor. And so that vicarious traumatization can be a really big deal, especially when we're dealing with people who are in criminal court, you know. Every serial killer had to have a lawyer on both sides who had to see and absorb that information from whatever it is that that person has done. So we do have to find ways to cope with and deal with that. So what do we do to achieve the balance? So I wasn't going to just give y'all all the information and then say, okay, bye. So we got to figure out, what are we going to do? So one, we got to figure out some healthy coping skills. Using the substances to cope, that's not working. So healthy coping skills can be things like journaling, yoga, meditation, become a comedian, use comedy, awesome. So healthy coping skills. And that might look different for everybody. My healthy coping skill is every now and then I do a mecation. I don't want to be bothered with anybody else. I don't want to compromise. It might be even local. I might check in a hotel for 3 days and just do what I want to do. Call you. That defeats the purpose. You'll be quiet. Okay, I'm gonna put you in a corner. Self-care. We don't take care of ourselves. We need to follow up with our doctors. We need to make sure that we are taking time for ourselves and that we're not always on the go. We need to remember that we are worth it. If we are so busy taking care of everybody else that we don't take care of ourselves, what happens? Now, my favorite analogy about self-care is the analogy of being on the plane. And they tell us if the cabin were to lose pressure and the mask fall down, that we need to put our mask on first, even if we have small children with us. That sounds counterintuitive. That sounds like we're unable to actually do that. But think of it in this sense. If all of your responsibilities are on the plane and you don't have your mask on, how many of those responsibilities are you going to get to if there's no oxygen? Not very many. So we have to put our mask on first. We have to take care of ourselves. One of the responses to my vacation idea is they have husbands and kids. I do know of some people that have been able to negotiate that one. So it kind of depends. But for some people, that doesn't sound like self-care. For some people, that sounds like torture to be in a hotel for 3 days and not be bothered with anybody. For me, it works. Healthy boundaries. This is a big one. Boundaries are the things that we put around ourselves to protect ourselves. As a therapist, if I don't have healthy boundaries, guess what? I see 30 clients in a week, 35 clients in a week, and I'm taking all of their issues home. I got 35 issues. That doesn't count my issues. I got 35 extra issues. So learning how to leave that at home. My clients have my cell phone number. That works for me for private practice, but oftentimes we discourage people. That works for me for private practice, though, because if they need to reschedule or if they're in crisis, they can get in contact with me. Now, if somebody sends me a message about rescheduling on a Saturday night, guess when they get answered? Monday morning. That's a little bit different. That's a little bit different. And so it depends on what type of law you're practicing, sure. But you get them out and then you talk to them Monday. So having those healthy boundaries. We all have to figure out what those boundaries are. The two cornerstones of healthy boundaries are knowing what your limits are and knowing what you value. So if you value family time, you're probably not going to be an attorney that works at a firm that requires a high number of billable hours because you want to spend time with family. So you may pick a different career path within the legal profession. So looking at what we value and also looking at what is it that our limits are. If we know our limits up front, then it's easier to put them in place. Good work-life balance. That looks different for everybody. The 25-year-old that's not married and doesn't have kids is going to look different from the 25-year-old who might be married and have a toddler. So that work-life balance is going to depend on what you have going on. But it can't be all work and it can't be all fun. We got to meet in the middle. We've got to have a little bit of both going on. Realistic goals and expectations. Goals should be measurable. They should be well-defined. They should be achievable. So sometimes we're setting goals and the goals just don't make sense. They don't work for what we need. If I tell y'all, okay, well, by New Year's Day, I'm going to lose 100 pounds. Is that a realistic goal? No, it's not happening. It's measurable. I can measure it, but it's not realistic. So our goals need to be realistic and true to what we can actually achieve. Another one is overcoming the stigma attached to mental health or mental illness. There is a huge stigma attached to getting help from mental health. Yes, especially in the African American community. It is getting better, But when we get caught in that stigma of what other people are going to think and what other people are going to say, we are sacrificing our well-being when there are people out there who are trained to help us. By law and by ethics, I can't tell anybody you came to see me. I'm not trying to lose my license to say, Mr. Such and such was in my office the other day. Therapists are bound by those guidelines. Another thing that we can do is to actually seek therapy. Therapy is something that I think everybody should do at some point in their lives. As therapists, they make us go whether you want to or not when you're in graduate school. But most therapists who are practicing have a therapist of their own or have had a therapist of their own. So it's important to do that process. And it's really not hard in today's world. You can do therapy through Zoom. You don't even have to go into an office. You have telehealth, thanks to COVID. Compliance with medication regimens. So for some of these disorders, we need medicine. And that's okay. If we have a heart condition, do we take our heart medicine? If we have diabetes, not all of us, but we're typically compliant with what we're supposed to take. If we have chronic back pain or whatever it is that we have that's physically wrong, we tend to go ahead and take the medicine. But then all of a sudden, when we start talking about medications for mental health, oh, that means I'm crazy. I can't take that. But we do need to be compliant if it's recommended. The other piece about both medication and therapy is it might not work out with the first therapist and it might not work out with the first medication. That does not mean we throw all of our help out the window. Just like we can have an attorney and don't like our attorney and find us a new one. We can have a therapist and not like our therapist and find a new one. We can have a medication that has too many side effects, so we move to something else. So there are options out there for us to actually be able to get help that works for us. My personality is not for everybody for therapy. I will refer you out to somebody who I think your personality will match with. And it's not personal. We just don't click. Because if you don't click with me, you don't trust me, we're not going to get any work done. Building a healthy support system. Oftentimes we're trying to do all of this stuff by ourselves. So having a good support system, having a group of colleagues that we can bounce ideas off of, having a support system outside of work that says, hey, you've been working too much, let's go hang out. Having a support system that we can call when we're distressed or that we can utilize to help us get through rough times. And remembering that we're not alone. There is help, there are resources, and there are people who love us and care about us who are willing to provide that support for us. So, resources. A really good one, the American Bar Association has a lawyer assistance program. If you go to their page, they have articles, they have videos, they have how to access services. Some of these services are actually free. And so if you need help, the Bar Association is recognizing that this is an issue. And they want to make sure that you're getting the services that you need. In terms of finding a therapist, Psychology Today is a good resource. Therapists set up profiles, and you're actually able to see a picture of the person, read what they specialize in, get a feel for how they do therapy before you select them. Another way to find a therapist is insurance provider panels. Got insurance, there's a list of people your insurance panel has who are approved for services through your insurance. The insurance for therapy works the same way as your insurance for your primary care physician. So whatever your copay is for primary care, it is the same copay when we talk about going to therapy. If anyone has any specific questions or needs any guidance, you can email me at charnel.jackson@sulc.edu. So, implications. Those who are in the field of law need better access to and education regarding mental health and the resources available to them. And the second part is we have to start early. These issues are beginning in law school. So if we start to put our resources in that area and focus on law students, we're then preventing a lot of these long-term struggles in which people are going through and taking into the profession with them. Because if we are helping people, because I think of law as being one of the helping professions, we've got to be okay to be able to help other people. If we're burnt out, tired, falling apart, how can we truly help other people? At least effectively. So, any questions? If you have them virtually, you can put them in the chat. If anybody here has questions, please feel free to ask. I just came back from one. I didn't know you then. But that's not a me-cation, that becomes a vacation. A vacation. So I have to have my me-cation at least a couple of times a year. Okay. Sometimes that does help if you have an assistant to kind of run your calendar so that there's a barrier between you and the clients and they know that they can't come directly to you. So it kind of depends. I don't mind sharing the presentation. If you email me, I will send you a copy. Well, we want to thank you for the presentation. Thank you guys so much for having me. We're going to take a short break while we reset. The next presentation is supposed to. We're going to take a short break. The next presentation starts at 9:45. We're going to start on time. Oh, it was a pleasure.